Starting off clinical cardiology with the star topic, and the star topic is pulse. A lot of us are still unclear with the concept of pulse. Pulse is a pressure wave and not the flow of blood. When you palpate your pulse, you are feeling the pressure wave and not the flow of blood through the artery. First, the definition of pulse. Pulse is defined under 4 points, and each of these points are significant for its definition. And these points are: pulse is a pressure wave which is palpated over peripheral artery against a bony prominence, which is produced or generated by the contraction of left ventricle or left ventricular systole. And then I'm going to give a tail to this star. So what is pulse? Pulse is a pressure wave palpated over peripheral artery against a bony prominence produced by the contraction or left ventricular systole. So how is pulse generated? It is generated by the contraction of left ventricle. So let's see that with the help of a diagram. This is your left atrium, this is the left ventricle, and this is your aorta. And if you know your cardiac cycle, you must know that during ventricular systole or during contraction of ventricle, the very first phase is isovolumetric contraction. In isovolumetric contraction, the valve in between the left ventricle and the aorta, which is the aortic valve, is closed. Since the aortic valve is closed, there is no communication between left ventricle and the aorta. As the left ventricle keeps on contracting, the pressure inside the ventricle becomes greater than the pressure inside the aorta. When the pressure inside the ventricle becomes greater than the pressure inside the aorta, the aortic valve opens completely. As soon as the aortic valve opens completely, now there is complete communication between the two systems of the heart, that is your left ventricle and the aorta. When two systems of the heart are in complete communication with one another, the pressure and volumetric changes in one system is faithfully transmitted to the other system. So I just mentioned 3 points, and these 3 points are actually 3 separate concepts that needs to be there in your head. So listen carefully. First, the left ventricle is contracting, but the pressure inside the left ventricle is less than the pressure inside the aorta, so the aortic valve remains closed. The left ventricle keeps on contracting. Eventually, a point comes when the pressure inside the left ventricle becomes greater than the pressure inside the aorta. At this point, the aortic valve opens. When the aortic valve opens completely, I repeat, completely, because there are pathological conditions like aortic stenosis where the valve does not open completely. Normally, valves, when they open completely. So when the aortic valve opens completely, now there is complete communication between the two systems of the heart. They are the left ventricle and the aorta. As a result, the pressure and volumetric changes in the left ventricle is faithfully transmitted to the aorta. And this is how. So as the left ventricle keeps on contracting, the pressure inside the left ventricle increases. This increment in pressure is faithfully transmitted to the aorta, that is inside aorta as well, the pressure increases by same extent. This increment in pressure brings about changes in the artery. What type of change? So the pressure, it applies perpendicular force against the wall of the artery. As a result, there is slight bulge on the wall. But then this pressure does not just stay there. This pressure from the aorta gets propagated throughout the arterial system along the wall of the artery. See, so I'm going to take an example. I'm going to take the example of the arterial system supplying your upper limb. So let's produce the aorta forward towards the upper limb. The aorta, when produced forward towards the upper limb, we get the brachiocephalic trunk, the subclavian artery, the axillary artery, the brachial artery, which bifurcates into ulnar artery, and the radial artery. The pressure change in the wall of the artery propagates forward like this. So now the bulge appears here. It further propagates forward, and then the bulge appears here. It further propagates forward till it reaches periphery. This propagating wave produced by the change in pressure in the artery manifested in the wall of the artery is your pressure wave. And the velocity at which this pressure wave is traveling is 5 meters per second. When the pressure wave generated by the contraction of the left ventricle traveling through the arterial system finally reaches the peripheral artery, you will be able to feel it with the tip of the finger like this. So you put the tip of the finger here. Due to the pressure wave, the wall of the artery bulges outside, and this wall strikes the tip of the finger. This is exactly the pulse that you are feeling. That while palpating, the pulse that you are feeling is actually the wall of the artery bulging outward due to the transmission of the pressure wave, which then strikes the tip of your finger. So the pressure wave is transmitting throughout the artery along the wall of the artery, which is causing the wall of the artery to bulge out, and at the periphery, when the wall of the artery bulges out, it hits the tip of the finger, and then you feel it in the form of pulse. And that is why pulse is pressure wave. Let me use an analogy. Let's say left ventricle is a generator, a pressure generator, which is connected to the arterial system, which I have shown here with the help of a compliant pipe. Now the pipe and the generator are in complete communication with one another. As a result, whenever the generator produces pressure, it gets faithfully transmitted to the pipe. This pressure travels through the pipe, propagates forward through the pipe along the wall of the pipe in the form of vibrations. This is exactly what is happening here. Here also the left ventricle is contracting, which is producing pressure. This pressure is then traveling throughout the arterial system along the wall of the arterial system in the form of pressure wave, and this pressure wave is causing bulging out of the artery wall, which you are feeling in the form of pulse. Now this is best felt against a bony prominence, because against a bony prominence the artery remains stable. And this is it. So what is pulse? Pulse is a pressure wave which is palpated over peripheral artery against a bony prominence produced by left ventricular systole. Another concept. So the velocity, see, when left ventricle is contracting, it is not just the pressure that is getting faithfully transmitted. The volume is also getting faithfully transmitted. Then where is this volume? Let's say this is the start line of a race. This race is between pressure wave and the volume of blood. So let me draw the volume of blood here. So this is the column of blood, or the volume of blood, the column of blood. And this is the start line for the race. The velocity at which the pressure wave is traveling or propagating is 5 meters per second. But the velocity at which the column of blood is traveling is 0.5 meters per second. That means when the left ventricle contracts, by the time the pressure wave reaches the peripheral artery, the blood is yet to come. The blood is behind. It's second in position. Pressure wave is there, but the blood has yet not arrived. Okay, so with that, hopefully you have understood the concept of pulse. I can't make it much more easier. Next up, assessment of pulse. You assess the following characteristics of pulse. You look at the rate of pulse, you look at the rhythm of pulse, you look at the volume of pulse, then you look at the character of pulse, then you look at the condition of the condition of vessel wall, you look at delay, whether there is radioradial or radiofemoral delay, and finally you palpate the peripheral pulses. Rate is best assessed over radial artery, rhythm is best assessed over radial artery, volume is best assessed over carotid artery, and character is best assessed over carotid artery. So remember, rate and rhythm radial artery, rate, rhythm radial artery, volume and character carotid artery, volume and character carotid artery. There are 4 exceptions in character which I'll tell you later. While assessing pulse, you always need to assess it for 1 whole minute, and here's why. What do we normally do? We go and assess pulse for 15 seconds. We count the number of pulse in 15 seconds, multiply it by 4, and that will give you pulse rate in 1 minute. But while doing so, you might miss out on the true rhythm of the pulse. For instance, let's say a patient has irregular pulse, but the irregularity of the pulse is only present at the last 15 seconds of 1 minute, let's say. Then if you palpate this pulse only for the first 15 seconds, the pulse will come out to be regular. But in fact, the irregularity is present at the last 15 seconds. So you will miss out on the irregular part of the pulse, and you will mistakenly or falsely interpret the pulse to be regular in rhythm. And that's going to be wrong. So you need to assess pulse for 1 whole minute. Okay, now we are going to look at each of the characteristics of pulse to be assessed one by one, starting off with the rate of pulse. The normal rate of pulse is 60 to 100 beats per minute. Abnormally, when there is less than 60 beats per minute, we call that bradycardia. When it's more than 100 beats per minute, we call that tachycardia. Bradycardia. There are physiological and pathological causes of bradycardia. The physiological causes of bradycardia are sleep, athletes, and expiration. The pathological causes of bradycardia are due to pathology at the level of SA node, pathology at the level of AV node, and pathology at the level of bundle branch. At the level of SA node, you get sinus bradyarrhythmia. At the level of AV node, you get AV block. And at the level of bundle branch, you get bundle branch block. The causes of sinus bradyarrhythmia are: number 1, hypothermia. Number 2, hypothyroidism. Number 3, cholestatic jaundice. Number 4, drugs such as beta blocker, calcium channel blocker, and digoxin. Number 5, sick sinus syndrome. And number 6, Cushing's reflex. Under AV block, we have primary heart block, first degree heart block, second degree heart block, and third degree heart block. Under second degree heart block, we have Mobitz type 1, Mobitz type 2, and 2:1. So that's bradycardia for you. Tachycardia. Tachycardia also has physiological and pathological causes. The physiological causes of tachycardia are exertion, pregnancy, children, emotion, and inspiration. The pathological causes of tachycardia are your high output states. I want you to mock up all the high output states, because if your Viva teacher asks you to mention all the pathological causes of tachycardia, you can mention the high output states. And if he also asks you, or he or she also asks you to mention all the causes of high volume pulse, you can plug the high output states there as well. So the high output states are: number 1, fever; number 2, pregnancy as mentioned here; number 3 or number 2, anemia; number 3, thyrotoxicosis; number 4, beriberi; number 5, liver cirrhosis; number 6, Paget's disease of bone; and number 7, arteriovenous fistula. So what are the high output states? Fever, pregnancy, anemia, thyrotoxicosis, beriberi, liver cirrhosis, Paget's disease of bone, and arteriovenous fistula. So earlier I mentioned that during inspiration you have physiological tachycardia, and during expiration you have physiological bradycardia. What's the physiology behind it? See, during inspiration the intrathoracic volume it increases and the intrathoracic pressure decreases. That is, the pressure inside the right atrium decreases. As a result, more blood gets sucked into the right atrium. So the right atrium is now filled with lots of blood. This lots of blood pushes against the wall of the right atrium, and the wall of the right atrium stretches, which activates lots of stretch receptors. The activation of stretch receptors in turn leads to inhibition of vagus nerve. Inhibition of vagus nerve means there is less inhibition of heart and an increase in heart rate. In expiration, on the other hand, there is decrease in intrathoracic volume, increase in intrathoracic pressure, increase in pressure inside the right atrium. So there is less blood coming into the right atrium, less stretch of the right atrial wall, less activation of the stretch receptors, less inhibition of the vagus nerve, more vagal activity, more parasympathetic activity, more suppression of the heart, and a reduction in heart rate. So in inspiration you have physiological tachycardia, and in expiration you have physiological bradycardia. Again, in inspiration there is increase in intrathoracic volume, there is decrease in intrathoracic pressure, there is increase in preload, that is the blood coming into the right atrium. As a result, there is increase in right atrial wall stretch. As a result, there is increased activation of stretch receptors. When more stretch receptors get activated, there is increased inhibition of vagus nerve. As a result, there is increase in heart rate. On the other hand, during expiration, there is decrease in intrathoracic volume, there is increase in intrathoracic pressure, there is decrease in preload, that is the blood coming into the right atrium is less. So there is decreased right atrial wall stretch. That means less stretch receptors are activated. So there is decrease in activation of stretch receptors. As a result, there is less inhibition of vagus nerve, or there is more activity of vagus nerve, which suppresses the heart and reduces the heart rate. Another concept is relative bradycardia. Normally, When the temperature increases by 1 degree Fahrenheit, your heart rate is supposed to increase by 10 beats per minute beyond the temperature of 102 degree Fahrenheit. But in relative bradycardia, there is disproportion. That means in relative bradycardia, due to various infections, the person get fever of temperature greater than 102 degree Fahrenheit. But with rise in temperature by 1 degree Fahrenheit, there is no rise in heartbeat by 10 beats per minute. So that's a relative bradycardia. That is, relative to the temperature, the heart rate is low. For the same temperature for which there is supposed to be a higher heart rate, the heart rate is low. It is seen in yellow fever, dengue fever, Q fever, enteric fever. And with that, we are done with rate. Next, we have rhythm. The normal rhythm of pulse is regular in nature. Abnormal rhythm is irregular. Irregular pulse can either be regularly irregular or irregularly irregular. How can you differentiate between regularly irregular, and irregularly irregular process? A bit of tongue twister for you. So what I'm going to do is show how these pulses are felt by tapping my finger against my palm. So if I'm palpating regular pulse, it would feel something like this. Tuck, 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 tuck. It is regular. If I palpate a regularly irregular pulse, it will look something like this. Tuck, 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 tuck. Even though it is irregular, it has a certain pattern to it. And finally, irregularly irregular pulse. Tuck, 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 tuck. It's patternless. It has no pattern. Regularly irregular pulse is seen due to pathology at the level of SA node, at the level of AV node, and at the level of ventricle. At the level of SA node, all sinus arrhythmia result in regularly irregular pulse. At the level of AV node, AV block. More specifically, the two types of AV block. Number one, atrial tachyarrhythmia with fixed AV block, and number two, second degree AV block cause regularly irregular rhythm. As for ventricle, number one, ventricular bigemini, and number two, ventricular trigemini cause regularly irregular pulse. As for irregularly irregular pulse, you have two, atrial fibrillation and a ventricular premature contractions. I put a star in front of atrial fibrillation. That is because if you go to your ward, you'll find out that lots of patients have valvular heart disease or structural heart disease, which is accompanied with atrial fibrillation. You'll find lots of patients with atrial fibrillation. So if you palpate an irregularly irregular pulse in these patients, you need to be able to differentiate whether the cause behind this type of pulse is atrial fibrillation or ventricular premature contraction. And how you can do so is with help of apex pulse deficit. Apex pulse deficit is heart rate minus pulse rate. And there are two ways to calculate it. Method number one. In method number one, you need two different individuals. One individual will auscultate the apex beat and calculate heart rate, and another individual is going to palpate the radial pulse and calculate the pulse rate. Both simultaneously. And then you can subtract heart rate from pulse rate, and that will give you apex pulse deficit. Or if you are alone, in that case what you can do is that you can auscultate the apex beat and palpate the radial pulse on your own. But you want to be able to count the number of heartbeat and count the number of radial pulse at the same time. So instead what you do is that you count the number of skip bits. Skip bits. What are skip bits? See, skip bits are those heartbeats for which there is no radial pulse. See, all you have to do is listen for the heartbeat and count the number of heartbeat for which you are unable to palpate a radial pulse for. Okay, so that's your skip bit. And the number of skip bits is equal to apex pulse deficit. If the apex pulse deficit is greater than 10, then it's for sure atrial fibrillation. If it is less than 10, then it is ventricular premature contraction, or it could be a slow atrial fibrillation. There are 4 ways to differentiate between atrial fibrillation and ventricular premature contractions, and they are: number 1, apex pulse deficit. If it is greater than 10, it is for sure atrial fibrillation. If it is less than 10, it's most probably ventricular premature contraction. If the jugular venous pulsation shows no A wave is absent, then it's atrial fibrillation. But if it is present, it's ventricular premature contraction. The S1 sound shows variable intensity, it is atrial fibrillation. But then the intensity is normal, it's ventricular premature contraction. With exertion or hand grip, if the irregularity of the pulse remains irregular, it is atrial fibrillation. But if the irregularity becomes regular, it is ventricular premature contraction. Why? See, what are ventricular premature contraction? They are the premature contractions of the ventricle as a result of ectopics. What are ectopics? Normally, in your heart, the impulse required for the contraction of the heart is generated at SA node. If this impulse is generated at any place other than SA node, then that's ectopic. If it is generated at atrium or AV node or ventricle or bundle branch, anywhere else, they are ectopics. And these ectopics, they bring about ectopic beats, which are your ventricular premature contractions. Ectopics are dependent on refractory period. With exertion, the refractory period reduces. As the refractory period reduces, the ectopics reduces. The number of ventricular premature contractions reduces, and the irregularity of the pulse changes to regularity. With that, we are done with rhythm as well. Up next, we have the volume of pulse. The volume of pulse is actually assessed by taking blood pressure, right? Not by palpating, but by taking blood pressure. So what you find out is the pulse pressure. Pulse pressure is systolic blood pressure minus diastolic blood pressure. And the normal pulse pressure is within the range of 30 to 60 mm of Hg. 30 to 60 mm of Hg. So what is the abnormality in the volume of pulse? Number 1, if the pulse pressure is less than 30 mm of Hg, then it is a low volume pulse or a hypokinetic pulse or a pulsus minimus. Similarly, if the pulse pressure is greater than 60 mm of Hg, then the type of pulse is a high volume pulse or a hyperkinetic pulse or pulsus magnus. First, low volume pulse. The cause of low volume pulse is low output state, and the low output states are number one, congestive cardiac failure. So if the heart fails to pump properly, it is unable to pump out enough volume of blood, so you get a low volume pulse. Number two, when the volume itself is low due to dehydration or due to cardiogenic shock or due to hypovolemic shock. In these three cases, that is dehydration, cardiogenic shock and hypovolemic shock, you also get what is known as a thready pulse. Thready pulse is characterized by low volume and high pulse rate. If low volume pulse is as a result of low output states, then high volume pulse is as a result of high output states. And guess what? I've already asked you to mock up all the high output states under the topic of pathological causes of tachycardia. So tell me, fatafat. Number one, fever. Number two, pregnancy. Number three, anemia. Number four, thyrotoxicosis. Number five, beriberi. Number six, liver cirrhosis. Number seven, Paget's disease of bone. And number eight, atriovenous fistula. Okay. Low volume pulse is also caused by stenotic lesion of the valve, because in stenotic lesion of the valve becomes narrow. As a result, low volume of pulse passes through it. This low volume of blood passes through it. For example, in mitral stenosis, less blood reaches the left ventricle, so less blood gets pumped out and you get a low volume pulse. In aortic stenosis, less blood gets pumped out of the left ventricle, so you get a low volume pulse. On the other hand, high volume pulse is seen in regurgitant lesion of the valve, like mitral regurgitation and aortic regurgitation, because the regurgitant lesions, they result in volume overload, and if there is volume overload, it will eventually lead to high volume pulse. So low volume pulse is seen in low output states, high volume pulse is seen in high output states. Low volume pulse is seen in stenotic lesions of valve, like mitral stenosis and aortic stenosis, while high volume pulse is seen in regurgitant lesion of valve, like aortic regurgitation and mitral regurgitation. And with that, we are done with the volume of pulse as well. Up next, character of pulse. Character of pulse as well as the volume of pulse is best assessed in carotid artery, except four characters of pulse, and they are pulsus alternans, pulsus paradoxus, and water hammer pulse are best assessed over radial artery, and pulsus bispheriens, B4 bispheriens, is best assessed over B4 brachial artery. Brachial artery. Remember, never palpate both carotid arteries at the same time. Like for other arteries, peripheral arteries, you'd palpate them at the same time and compare both of them. But carotid artery, don't do that. Up next is a really interesting topic, and a topic that is difficult to interpret if you don't understand the logic behind it. And that is the aortic pulse waveform. If you flip through your clinical book, you'll find a waveform something like wah with a notch in between. That's your aortic pulse waveform. But then if I just blatantly draw that wave on the screen and explain what each of the part of that wave stands for, you won't understand anything. So what I'm gonna do instead is draw the various phases of cardiac cycle and then show how in each of these phases of cardiac cycle pressure changes occur inside the aorta, and it is due to the various pressure changes that occur into the aorta in various phases of cardiac cycle that you get that particular aortic pulse waveform present in your clinical books, that wah. So let's see how that wah is created with the help of cardiac cycle. All right, starting cardiac cycle with ventricular systole. Normally, when the aortic valve is closed, the pressure inside the aorta is the diastolic blood pressure, which is normally around 80 mm of Hg. It is only when the pressure inside the ventricle becomes greater than the pressure inside the aorta that the aortic valve will open. In isovolumetric contraction of the ventricle, the pressure inside the ventricle increases from 5 mm of Hg till 80 mm of Hg. This is isovolumetric contraction. In isovolumetric contraction, the pressure is not strong enough to open the valve. As a result, there is no communication between left ventricle and aorta. As the ventricle continues to contract, eventually a point comes when the pressure inside the ventricle becomes greater than the pressure inside the aorta. As soon as the pressure inside the ventricle becomes greater than the pressure inside the aortic valve opens. Once the aortic valve opens completely, now the two isolated systems of the heart are in complete communication with one another. When two isolated systems of the heart are in complete communication with one another, in this case, the left ventricle is communicating with the aorta, the pressure and volumetric changes in left atrium is faithfully transmitted to aorta. Three concepts that I have already asked you to keep it in your head while I explained you the definition of pulse. See, that was the relevance of the three concepts here. They are being applied right now in cardiac cycle. Okay, let's not use our brain that much. Let's use it a little less. So the ventricle starts to contract. The contraction is not strong enough to open the aortic valve. This is isovolumetric contraction. The contraction keeps on increasing and the pressure inside the left ventricle becomes greater than the pressure inside the aorta. As soon as that happens, the aortic valve opens. As soon as the aortic valve opens, the increase in pressure inside the ventricle is faithfully transmitted to the aorta as well. That means the maximum capacity till which the ventricle can contract is the systolic blood pressure. So it will contract till 120 mm of Hg. Inside aorta as well, the pressure will increase till 120 mm of Hg, which is the systolic blood pressure. So in isovolumetric contraction, inside aorta, you had diastolic blood pressure of 80 mm of Hg. After isovolumetric contraction, in rapid ejection, the pressure increases from diastolic blood pressure to systolic blood pressure inside aorta. And this increase in pressure is as a result of left ventricular systole, which in waveform is represented with the help of this red line referred to as the percussion wave. This is referred to as the percussion wave. So percussion wave. Every time you palpate a pulse, what you are feeling is the percussion wave. That is, the left ventricle contracts, percussion wave is generated as the pressure inside the aorta increases from diastolic blood pressure to systolic blood pressure, and then this wave travels along the wall of the aorta to the peripheral artery, and then you feel that pulse. You feel the percussion wave. Okay, good. Till here, everything's fine. Okay. The ventricle keeps on contracting, but now instead of the contraction happening at apex, more of the contraction is happening at the base of the ventricle, which is relatively weaker. Since the contraction is weaker, the pressure inside the ventricle, it starts falling. See, contraction is taking place still, but the contraction is weaker, so the pressure falls. The two systems are still in complete communication with one another, so the pressure change inside the ventricle is reflected inside the aorta. So here also the pressure, it starts to decrease. From 120, it starts falling down. So what do you get? You get this. The same thing here. Now the pressure starts to fall down. Pressure starts to fall down. Okay. As soon as the pressure that is falling hits around 90 mm of Hg, the pressure inside the left ventricle becomes around 90 mm of Hg, 85 to 90 mm of Hg, the aortic valve closes. As soon as the aortic valve closes, the column of blood inside the aorta falls back. As the column of blood inside the aorta falls back, there is a transient drop in pressure inside the aorta. Transient drop in pressure inside the aorta. And this transient drop in pressure inside the aorta is represented with the help of a notch. This notch is referred to as the dicrotic notch. This is your dicrotic notch. So dicrotic notch represents a transient fall in pressure inside the aorta due to the backward fall in the column of blood inside the aorta due to the closure of aortic valve. Aorta, it's a large artery, and large artery are elastic in nature. So as pressure gets built up inside the aorta, it dilates and the wall stretches. As soon as the valve closes, now this highly stressed aorta recoils back. So the stressed aorta recoils back. Due to the recoiling of the aorta, it squeezes the blood inside it, which results in transient rise in pressure. There is transient rise in pressure. A transient rise in pressure. This transient rise in pressure due to the recoil of aorta is referred to as the dicrotic wave. Dicrotic wave. As the aorta recoils, it squeezes out the blood inside it to the periphery. As the blood gets squeezed out, now there is no blood inside the aorta, so the blood pressure inside the aorta falls. The pressure inside the aorta falls. It falls just like this, and this is referred to as diastolic runoff, because the blood inside the aorta is running away as the ventricle is under diastole, so it is referred to as diastolic runoff. And with that we are done with the various phases of cardiac cycle representing the various parts of aortic pulse waveform. Let me revise it for you. So this is what happens. First, the left ventricle starts to contract. The very first phase of left ventricular systole is isovolumetric contraction. In isovolumetric contraction, the pressure inside the ventricle is less than the pressure inside the aorta. So the aortic valve does not open. Since the aortic valve does not open, there is no communication between left ventricle and aorta. And inside the aorta, the pressure that is present is the diastolic blood pressure. As soon as the pressure inside the ventricle becomes greater than the pressure inside the aorta, the aortic valve opens. As soon as the aortic valve opens completely, now the left ventricle is able to communicate with the aorta. As a result, if there is rise in pressure inside the aorta, inside the ventricle, there is also rise in pressure inside the aorta by same extent. That means as the pressure inside the left ventricle increases from diastolic blood pressure to systolic blood pressure, inside aorta as well, the pressure increases from diastolic blood pressure to systolic blood pressure. And this is represented in aortic pulse waveform with the help of a rise, which is called the percussion wave. When you palpate the peripheral pulse, you are feeling the percussion wave. Then the contraction of the ventricle shifts from apex to base, and the contraction is relatively weaker. As a result, what you get? So there was isovolumetric contraction, then rapid ejection, then a slow ejection. That is, the ventricle is still contracting, but it is contracting weakly. So there is fall in the pressure. With fall in pressure inside the left ventricle, there is also fall in pressure inside the aorta by same extent. As soon as the pressure falls to around 90 mm of Hg, as soon as it falls to around 90 mm of Hg, the aortic valve closes. Due to closure of the aortic valve, a column of blood in the aorta, it falls back. Due to the downward fall of the column of blood, there is a transient drop in the pressure inside the aorta. And this is represented with the help of dicrotic notch. So dicrotic notch is as a result of closure of aortic valve. Aorta is highly compliant. It is elastic. As blood and pressure gets accumulated inside the aorta throughout the phase of systole, throughout the ventricular systole, it has expanded. But now as ventricular diastole has started, the aorta is gonna recoil back. As the aorta recoils back, it squeezes the blood inside and transiently increases the pressure, which is represented by dicrotic wave. Then it squeezes all the blood from inside the aorta to the periphery. So there is again fall in pressure inside the aorta back to diastolic blood pressure, which is represented by diastolic runoff, because the blood inside the aorta is running away to the periphery while the ventricle is going through diastole. Understanding the various types of pulse. Very first, you have the normal pulse, which is also referred to as the catacrotic pulse. So what I have explained till now with the help of various phases of cardiac cycle, showing the different changes in pressure inside the aorta with each phase of cardiac cycle in the form and then represented in the form of a pulse waveform, was your catacrotic pulse. A catacrotic pulse has an ascending limb and a descending limb. The ascending limb is also referred to as the anacrotic limb, and the descending limb is also referred to as the dicrotic limb. So it has an ascending anacrotic limb and a descending dicrotic limb. So what did we have? First, inside the aorta, the pressure that was present during the isovolumetric contraction was the diastolic blood pressure. As the left ventricle contracts and the aortic valve opens, the pressure inside the ventricle increases from diastolic blood pressure to systolic blood pressure, which gets faithfully transmitted to aorta. So inside aorta also pressure increases from diastolic blood pressure to systolic blood pressure. This increase in pressure inside the aorta is represented in the waveform with the help of a uphill that I have shown with the color red, and this is referred to as the percussion wave. When you palpate your peripheral artery, what you are feeling is the percussion wave, and the maximum intensity of the pulse that you are feeling is the peak of the percussion wave. How? So the left ventricle contracts. The pressure inside the left ventricle increases from diastolic blood pressure to systolic blood pressure. As the aortic valve is open, the pressure inside the aorta also increases from diastolic blood pressure to systolic blood pressure. And then this pressure increment travels throughout the arterial system along the wall of the aorta in the form of pressure wave and reaches the periphery. The part of the pressure wave that is reaching the periphery is the percussion wave, because this part involves the increment of the pressure from diastolic to systolic blood pressure. So what you are feeling is the percussion wave. Okay, after that, the contraction of the left ventricle decreases and the pressure inside the left ventricle decreases and the pressure inside the aorta also decreases. When the pressure inside the left ventricle becomes around 90 mm of Hg, the aortic valve sorts off. As soon as the aortic valve opens, there is fall in the column of blood inside the aorta, which results in a transient fall in blood pressure represented in the pulse waveform with the help of a notch. And this notch that I have shown right here is called the dicrotic notch. So what is dicrotic notch? Dicrotic notch is representing the closure of aortic valve, resulting in transient fall in pressure inside the aorta due to fall back of the column of blood. Then the highly compliant aorta that has fattened up or dilated or stretched throughout the systole. Throughout the systole, the ventricle is pushing the blood into the aorta, pushing blood and pressure into the aorta, and the aorta has fattened up. Now it is gonna recoil back. As soon as the aortic valve sorts off, it is gonna recoil back. The recoil is gonna produce pressure inside of it, and this is represented by another wave, which is called the dicrotic wave. The squeeze, the recoil of the aorta is going to push all the blood to the periphery, and there is sudden drop in pressure inside the aorta, and this is your diastolic runoff. Diastolic runoff. And the pressure inside the aorta falls back to diastolic blood pressure. Diastolic blood pressure. The difference in between the peak of the wave and the bottom of the wave, or the difference in between systolic blood pressure and the diastolic blood pressure, will give you pulse pressure. When this pulse pressure is less than 30 mm of Hg, that is, if the wave was like this, right, the difference would have been less than 30 mm of Hg, then that would have been low volume pulse. If the difference was greater than 60 mm of Hg, that is, the wave would have been like this, a high peaking wave, that is pulse pressure greater, larger than 60 mm of Hg, then this would have been a high volume pulse. At this point, at the level of dicrotic notch, what is happening? There is closure of aortic valve. Closure of aortic valve represents the end of ventricular systole and the beginning of ventricular diastole. So from starting till here is systole, and from here to here is diastole. The closure of aortic valve also produces the second heart sound, or the S2 sound. So there is S2 sound here. In the beginning, there was isovolumetric contraction where there was closure of mitral and tricuspid valve, which produced the first heart sound, which is the S1 sound. And you know that in between S1 and S2 you have systole, and the S1 repeats again here, and between S2 and next S1 you have diastole. This limb right here is the anacrotic ascending limb. Okay, the anacrotic ascending limb, and this limb right here is the dicrotic descending limb. Dicrotic descending limb. One more concept that you need to understand for normal pulse or catacrotic pulse is that in some of the clinical books, after percussion wave, what you also see is a tidal wave. What is tidal wave? See, when the left ventricle contracts, it squeezes the blood out of the aorta, producing percussion wave. This percussion wave is the forward wave that travels to the periphery. As the percussion wave travels forward, it is going to collide with arteries at the points where the arteries bifurcate, and at the points where the arteries become smaller, the wave is going to collide. After the percussion wave collides, it returns back or reflects back. So you have two waves, the percussion wave moving forward and the reflected wave moving backward. These two waves, when they meet each other, they attenuate. What is attenuation? Attenuation is when two things, they merge and become bigger. So here as well, one wave is moving forward, the other wave is moving backward. Both of them, they collide and then increase in intensity. This is tidal wave. So left ventricle contracts, percussion wave moves forward, it gets reflected back from the periphery, The percussion wave and the wave reflected back, they collide with one another and increase in intensity, producing a new wave called the tidal wave. Okay, now let's look at the various abnormal pulses. And I'm going to teach you these abnormal pulses on the basis of pathologies. So in certain pathology, you have certain type of abnormal pulses, and in other pathologies, you get other type of abnormal pulses. Starting off with aortic stenosis. Okay, what is aortic stenosis? Aortic stenosis is the narrowing of the aortic valve. As a result, when the left ventricle contracts, only small amount of blood gets ejected out with each contraction, which results in either pulsus tardus or pulsus parvus et tardus, also referred to as pulsus anacroticus. Pulsus tardus. Tardus comes from the word tardy, which means late or slow. So what you get is a slow peaking, slow rising pulse. That is, the pulse rises slowly. It looks something like this. So the pulse rises slowly. It eventually reaches the peak, but then the rise is slow. It's a slow rising pulse. It reaches the peak, and from your normal pulse, you must know that the peak is the systolic blood pressure. What is the peak? The peak is the systolic blood pressure. Second is pulsus parvus et tardus, where parvus means low peaking. Tardus was slow rising, parvus is low peaking. Here you get low peaking, slow rising pulse, which looks something like this. So there is slow rise, plus the pulse never reaches the peak. It never reaches the maximum intensity. So there is slow rising and low peaking pulse. Since you have low peaking pulse, you get a low systolic blood pressure. Since you have a low systolic blood pressure, the difference between systolic blood pressure and the baseline representing the diastolic blood pressure is low. That is, the pulse pressure is low, less than 30 mmHg, which is referred to as low volume pulse. And that is why I asked you to remember low volume pulses to be seen in number 1, low output states, and number 2, stenotic valvular lesions like aortic stenosis and mitral stenosis. See, you can either use your common sense or the graph. Common sense is that since there is obstruction in the outflow of the left ventricle, when the left ventricle contracts, only small volume of blood gets squeezed out, giving us a low volume pulse. And the concept of graph is that since you get a low peaking pulse, the difference between systolic blood pressure and diastolic blood pressure is low as well, so giving us low volume pulse. Now, why slow rising? Why low peaking? Let's understand. You get a slow rising pulse because with each contraction, the ejection of volume of blood is very slow because there is obstruction, and you get a low peaking pulse because there is obstruction. So with each contraction, only small volume of blood gets ejected out. That means there is decrease in stroke volume and a decrease in systolic blood pressure. See, decrease in systolic blood pressure because there is decrease in stroke volume due to fixed obstruction present right here. Next is aortic regurgitation. Normally, when the left ventricle relaxes, the aortic valve shuts off, preventing the backflow of blood from aorta to ventricle. In aortic regurgitation, due to pathology of the aortic valve does not close at ventricular diastole. As a result, there is backflow of blood from aorta into the ventricle in ventricular diastole. So during ventricular diastole, the left ventricle is receiving blood from two places. One from backflow from aorta, another from left atrium. So it is filled with lots of blood. This lots of blood is going to push against the wall of the ventricle, which causes the left ventricle wall to stretch. And as per Starling force, the more the wall of the ventricle stretches, the strongly it contracts. So it's gonna contract strongly, and as the left ventricle contracts strongly, it's gonna push all that blood strongly out of the aorta to a long distance, giving us a sudden rising pulse, which is referred to as bounding pulse or water hammer pulse or Watson's pulse or pulsus sellis or collapsing pulse or Corrigan pulse. Okay, let me show you with the help of graph. So there is a sharp rise and a sharp fall. There is a sharp rise in pulse and a sharp fall in pulse. Since there is sharp rise, what do you have? You have a high systolic blood pressure. And when there is high systolic blood pressure, there is huge gap between baseline and systolic blood pressure, or pulse pressure is greater than 60 mm of Hg, giving us high volume pulse. And that is why I asked you to remember under high volume pulse two causes. Number one is high output state, and number two is regurgitant lesion of the heart like aortic regurgitation and mitral regurgitation. Okay, why the sharp rise and sharp fall? Sharp fall because when the ventricle goes through, arey bhai, this marks the end of systole. So this much is systole and this much is diastole. And during diastole, when the ventricle relaxes, it's receiving blood back from the aorta. The aortic valve does not sort of, so the blood, it falls back. So there is drop in the pressure inside the aorta. So there is a sharp fall. Once the ventricle is filled with lots of blood, it is going to contract strongly. So it squeezes out blood rapidly, giving us a sharp rise. That's why a sharp rise and a sharp fall in aortic regurgitation, which is referred to as a bounding pulse or water hammer pulse. Second, we can also see pulsus bispherians. What is pulsus bispherians? Very easy. Bis means 2. So there are 2 peaks in systole. 2 peaks in systole. See, here's the dicrotic notch which marks the end of systole. So this much is systole. And in one systole, there's the first peak and then the second peak. Why? The first peak is as a result of percussion wave. Percussion wave is as a result of left ventricular contraction. And the second peak is as a result of tidal wave. So I mentioned tidal wave earlier. What is happening? The left ventricle is contracting strongly and the blood is getting squeezed out strongly, producing percussion wave. This wave strikes to the periphery and gets reflected back, and then the forward moving percussion wave and backward coming reflected wave hit one another, increase in intensity, producing tidal wave and the second peak. All of that is happening in the systole itself. Next is hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy, there is hypertrophy of the wall of the ventricle, but the hypertrophy is asymmetrical, due to which there is more hypertrophy of the interventricular septum. Number one. Number two, in hypertrophic obstructive cardiomyopathy, the heart is hyperkinetic. That means it contracts vigorously. So now understand. Every time the left ventricle contracts, the hypertrophied interventricular septum, it shortens and bulges into the lumen. As it bulges into the lumen, it is going to cause obstruction to the left ventricular outflow. So there is left ventricular outflow obstruction every time the left ventricle contracts. This is hypertrophic obstructive cardiomyopathy. It gives us pulsus bispherians. In pulsus bispherians, what did we have? We had 2 peaks in systole itself. First peak and second peak. And you also get spike and dome. Spike and dome means there's a sudden rise in pressure and then plateau. Here is systole. Within the systole, there is your peak and then a dome. Now, why is there a peak and a dome? See, why is there a sort? I just said that it is going to obstruct the outflow. If it is obstructing the outflow, should it not be like aortic stenosis? Should there not have been pulsus tardus, pulsus parvus et tardus? No, because the obstruction here is dynamic. The obstruction in aortic stenosis was fixed. Dynamic means it is only when the ventricle contracts that the interventricular septum, it plops in and obstructs the outflow. So this is what happens during systole. The ventricle contracts, ventricular systole takes place during the very initial instant. Since you have a hyperkinetic heart, that is a strongly contracting heart, the blood gets pumped out very strongly, producing the peak. But immediately, due to shortening of the interventricular septum, there is obstruction of the left ventricular outflow, and then again you get a dome. So the peak is due to strong contraction by the hyperkinetic heart, and the dome is due to the obstruction by the shortening and plopping of the hypertrophied interventricular septum, giving us spike and dome or jerky pulse. Next is dilated cardiomyopathy, as well as in second week of typhoid, you get dicrotic pulse. In dilated cardiomyopathy, the ventricle is dilated and the heart is large in size. Plus, the heart is hypokinetic. Unlike HOCM, here is hypokinetic. Here you get pulsus dicroticus, which means there are two peaks. One peak, di means two. One peak is present in systole and the other peak is present in diastole. First peak and second peak. The first peak is as a result of percussion wave due to the contraction of the ventricle, and the second peak is as a result of exaggeration of dicrotic wave. See, if you remember your normal wave, this is what it looks like. Percussion wave, fall, dicrotic notch, and a dicrotic wave and a diastolic runoff. If I grab this dicrotic wave and produce it forward, will I not get a second peak? That is exactly what is happening here. So one is in systole and the other is in diastole. Next, left ventricular failure. Here also you get pulsus dicroticus. One peak in systole and the other peak in diastole due to the exaggeration of dicrotic wave. Systole, diastole, first peak, second peak. What you also get in left ventricular failure is pulsus alternans. In pulsus alternans, you have alternating high volume and a low volume pulse. Again, a high volume and a low volume pulse. The question is why? See, in left ventricular failure, some of the fibers of the left ventricle are normal, some of the fibers are deranged. Due to the normal fibers, you get high volume pulse. Due to the deranged fiber, you get low volume pulse, giving us alternating high volume, low volume, high volume, low volume pulse, also referred to as pulsus alternans. Finally, you have digoxin toxicity producing pulsus bigemini. This is pulsus bigemini. So there's your normal pulse. All of a sudden, at this point, you get ventricular premature contraction or ectopic beat, which produces secondary pulse. The same thing repeats after a pause. The same thing repeats after a pause. This pause is the compensatory pause. Compensatory pause. See, bigemini means twin, and your pulse has a twin. This is the pulse, this is the main pulse, and this is the second pulse due to ectopic beat. This is kind of like the twin of the main pulse. So you call it pulsus bigemini. Pulsus bigemini contains ventricular premature contraction, then compensatory pause, then ventricular premature contraction, compensatory pause, alternatively, one by one. So those were the various pulses. Finally, you have pulsus paradoxus. I'll explain it in a while. First, let's revise all these pulses, okay? Let's revise them all. First, you had aortic stenosis with pulsus parvus and with pulsus tardus and pulsus. All right, let's revise all the abnormal pulses before getting into pulsus paradoxus. First, in aortic stenosis, you had pulsus tardus, which is a slow rising pulse. Number 2, pulsus parvus et tardus, which is a slow rising and a low peaking pulse, also referred to as pulsus anacroticus. Second, in aortic regurgitation, you had water hammer pulse or bounding pulse with a sharp rise and a sharp fall, and pulsus bisferiens, which had two peaks in a single systole. Next, hypertrophic obstructive cardiomyopathy. It also had pulsus bisferiens, that is two peaks in systole, as well as spike and dome, which contained a spike and a dome in the systole. Then dilated cardiomyopathy. It had pulsus dicroticus, that is one peak in systole and the other peak in diastole. Then left ventricular failure with pulsus dicroticus, one peak in systole, other peak in diastole, as well as pulsus alternans with alternating high volume, low volume pulse. Then in digoxin toxicity, we had pulsus bigemini with a normal pulse, then ventricular premature contraction giving us a tween of the pulse and then a compensatory pause. Again repeat. And then finally, in second week of enteric fever, typhoid fever, second week of typhoid fever, you had pulsus dicroticus as well. That is one peak in systole and the other peak in diastole. So those are the various abnormal pulses, right? Aortic stenosis, pulsus tardus, pulsus parvus et tardus, aortic regurgitation, the bounding pulse or water hammer pulse, and pulsus bisferiens, hypertrophic obstructive cardiomyopathy with pulsus bisferiens and spike and dome, dilated cardiomyopathy and second week of typhoid, pulsus dicroticus, left ventricular failure with pulsus dicroticus and pulsus alternans, and digoxin toxicity with pulsus bigemini. Then we have pulsus paradoxus, something that you really need to understand, a highly conceptual question and a topic with lots of viva questions. Before understanding pulsus paradoxus or the pathology behind pulsus paradoxus, you need to know the normal physiology. The normal physiology is that during inspiration, the systolic blood pressure, it decreases. How? During inspiration, the intrathoracic volume, it increases and the intrathoracic pressure, it decreases. So the pressure inside the right atrium also decreases. As a result, lots of blood gets sucked into the right atrium. That is, there is increase in preload. This lots of blood then flows into the right ventricle. Inside the right ventricle, this lots of blood is gonna push against number one, the free wall, and number two, the interventricular septum. Since the free wall is fixed with the pericardium, it is the interventricular septum that gets affected. That is due to the push by the lots of blood in the right ventricle, the interventricular septum gets slightly pushed to the left side. As the interventricular septum gets pushed to the left, the space inside the left ventricle decreases. So number one, there is decrease in the cavity size of the left ventricle during inspiration. Number two, the decrease in pressure is not just in the right atrium. The pressure decrease is also in the lung. As a result, the lung, it holds blood with itself. So there is less filling of the left atrium. Since there is less blood in the left atrium, there is also less blood in the left ventricle. So point number two, less filling of the left ventricle. So during inspiration, two things are happening. Number one, there is decrease in the cavity size of the left ventricle. And number two, there is less filling of left ventricle with blood. As a result, there is decreased cardiac output and a decrease in systolic blood pressure. Normally, the decrease in systolic blood pressure is by less than 10 mm of Hg. It is only when in certain pathologies that the systolic blood pressure decreases by more than 10 mm of Hg do we call it pulsus paradoxus. So the fact is that pulsus paradoxus is not actually the measurement of your pulse, but instead the measurement of your blood pressure, more specifically the systolic blood pressure. Okay, let's revise what I have said just now. Physiologically or normally, this is what goes on. Normally, with inspiration, the intrathoracic volume increases and the intrathoracic pressure, it decreases. As a result, the pressure inside the right atrium also increases, and the preload into the right atrium increases. So there is lots of blood inside the right ventricle which pushes the interventricular septum to the left, which results in decreased cavity size of left ventricle. So that's number one. This is number one. The decrease in pressure is not just in the right atrium. There is also decrease in pressure in the lung. As a result, the blood, it retains blood. It holds blood in itself. So there is number two, less filling of left ventricle through left atrium. So less filling of left ventricle. Due to both these reasons, that is decrease in cavity size of the left ventricle due to push at the interventricular septum and due to decreased filling of the left ventricle due to holding of the blood by lung, you get a reduced cardiac output and a reduced systolic blood pressure, which is by less than 10 mm of Hg. While in pulsus paradoxus, what you get is the same thing. It is nothing but the exaggeration of normal physiology. So instead, in drop in systolic blood pressure by less than 10 mm of Hg, the drop in systolic blood pressure during inspiration is by more than 10 mm of Hg. It's by more than 10 mm of Hg. Pulsus paradoxus is seen in pathologies associated with cardiac causes and non-cardiac causes. The cardiac causes are, number one, cardiac tamponade. Number two, constrictive pericarditis. And the non-cardiac causes are, number one, acute exacerbation of COPD. Number two, acute severe asthma. Number three, tension pneumothorax. And number four, pulmonary embolism. The graph would look something like this. So this is your normal pulse waveform, right? The peak represents the systolic blood pressure. As inspiration goes on, the systolic blood pressure, it falls. And I have just mentioned you to two reasons why there is decrement in cardiac output and a fall in systolic blood pressure. This takes place normally as well, physiologically as well. It is only when the drop in systolic blood pressure is more exaggerated by more than 10 mm of Hg, we call it pulsus paradoxus. The question is, so in fact, pulsus paradoxus is not the measurement of your pulse, but the measurement of your blood pressure, more specifically the measurement of your systolic blood pressure. Then where's the paradox here? What is the paradox? Here's the paradox. Okay, let me just explain it. I don't really have to write it. You will understand it from explanation. Okay, this is the paradox. During pulsus paradox, the contraction of the left ventricle is weak due to fall in systolic blood pressure. There is massive fall in systolic blood pressure during inspiration. See, in pulsus paradoxus, during inspiration, the fall in systolic blood pressure is by more than 10 mm of Hg. And at this point, the contraction by the left ventricle is not strong enough to produce a pulse. So, when you get a patient with pulsus paradoxus, you auscultate the heartbeat and palpate the radial pulse. During inspiration by the patient, you will find that You are able to hear the heartbeat, but you are unable to feel the pulse. That is the paradox. The paradox is that even though there is heartbeat, there is no pulse. Got it? See, there is a patient with pulses paradoxus. You go and auscultate his chest for heartbeat and palpate his radial pulse at the same time. During expiration, okay, you are able to hear the heartbeat and you are able to palpate the pulse. But during inspiration by the patient, the systolic blood pressure decreases by so much so that the contraction of the left ventricle is not strong enough to produce pulse. So at that time, you are able to auscultate the heartbeat but unable to feel the pulse. That is the paradox. Right now, I'm going to take a fresh new slide to explain about water hammer pulse. And trust me, you don't have to screen through multiple resources, watch multiple YouTube videos to understand about water hammer pulse, because I'll explain about it under all topics. That is, what is water hammer pulse? What are the various names of water hammer pulse? Why those names have been given to it? Where do you get to see water hammer pulse? Why does it occur? What is the waveform of water hammer pulse? And how can you elicit it? Okay, let's begin. So the topic is water hammer pulse, which is also referred to as collapsing pulse. First thing first, where do you get to see water hammer pulse? So you can appreciate water hammer pulse in patients with aortic incompetency or aortic regurgitation. Number 2, in patients with high volume pulse. But remember this very important line. All collapsing pulse are high volume pulse, but let me give a big but here, but all high volume pulse are not necessarily collapsing in nature. That means if a person has collapsing pulse, the pulse is high volume in nature. But just because a patient has high volume pulse, that doesn't mean the pulse is gonna be collapsing in nature. Okay? Alright. So let's take the most famous example, that is of aortic regurgitation. In aortic regurgitation, here's your left atrium, here's your left ventricle, and here's your aorta. See, when the left ventricle relaxes or goes through ventricular diastole, the aortic valve closes to prevent the backflow of blood from aorta into the ventricle. But in aortic regurgitation, due to pathology in the aortic valve, it is unable to close properly. As a result, there is backflow of blood from aorta into the ventricle during ventricular relaxation. So ventricular diastole receives blood from two parts. Number 1, the left atrium, which is normal, and number 2, from aorta as well via backflow due to incompetent aortic valve. Since the left ventricle is filled with lots of blood, it is gonna push against the left ventricular wall and cause it to stretch. The large amount of blood causes the wall of the left ventricle to stretch. And as per Starling law, the more the wall of the ventricle stretches, the more strongly it contracts back. So it's so strong contraction. And it is due to the strong contraction of the ventricle that the blood gets pushed out of the ventricle through the aorta to the periphery, and there is sharp rise in pressure inside the aorta. There is sharp push of the blood out into the aorta. There is sharp rise. So why is there sharp rise? The sharp rise is due to the strong contraction of highly overfilled left ventricle. But then when the ventricle relaxes, the blood from the aorta, it regurgitates back. As a result, there is sudden fall in pressure inside the aorta. There is a sharp fall as well. There is a sharp rise and a sharp fall. Okay, so why is there sharp rise? The sharp rise is as a result of strong left ventricular systole following the stretch. And why is there sharp fall? The sharp fall is because of regurgitation of blood from aorta to left ventricle. Regurgitation. Okay. All right. So that's the pulse waveform. Now, what are the various names given to it? Water hammer pulse is referred to as collapsing pulse because when the ventricle relaxes, there is sudden drop in blood pressure as the blood falls back suddenly. So there is rapid downstroke of blood due to regurgitation. Why is it called bounding pulse? It's called bounding pulse because the rapid upstroke due to strong contraction of the left ventricle hits your fingertips like third of a hammer, See, since there is a rapid upstroke due to strong contraction of the left ventricle, the pulse it's quite strong and the pulse hits against the tip of your finger like a third of a hammer. That's why it's called bounding pulse, a strong striking pulse. Why is it called a water hammer pulse? It's called a water hammer pulse because it shows phenomenon like a toy called water hammer. In this toy, what you have is a cylindrical glass tube which is closed from both the ends and it is filled with water halfway and half of the tube is vacuum. So when you shake the tube, the water jumps up and when it falls down so strongly that it hits the end of the glass tube producing a third sound. So this is similar to your water hammer pulse because when the column of blood the pressure wave strikes the peripheral artery, you can feel it like the thud of a hammer. You can feel a strong pulse. Why is it called a Watson's pulse? It's called a Watson's pulse because the name was named by the water hammer pulse was named by Thomas Watson. All right, since there is a sharp rise in pressure, obviously the systolic blood pressure is high. Since the systolic blood pressure is high, the difference between the baseline and the peak is also high. That means the pulse pressure is greater than 60 mm of Hg, and that is why what you get is a high volume pulse. Now let's see how we can elicit this water hammer pulse or collapsing pulse in a patient while bedside. To elicit water hammer pulse, first you need to make sure that the patient doesn't have any shoulder injury, shoulder pain or shoulder discomfort. That is because while eliciting this pulse, there is gonna be movement at the shoulder joint. Second, in order to elicit water hammer pulse in the right upper limb of the patient, you are gonna stand on the right side of the patient and use your right palm, and vice versa. That is, if you have to elicit water hammer pulse on the left upper limb of the patient, you use your left palm. Now, with your right palm, you are going to wrap it around the right wrist of the patient, making sure that the waves of the palm lie over the radial artery while the rest of the palm lies over the ulnar artery. So you wrap around the wrist from behind such that the waves lie over the radial artery and the rest of the palm will automatically lie over the ulnar artery. On doing so, you will be able to feel a strong pulse if the person has aortic regurgitation. Now, start squeezing the wrist till the pulse is obliterated. Then release tension slowly from the wrist till the pulse is feebly or lightly felt. Then with the help of your left hand, provide support just below the elbow joint because you want movement only at the shoulder joint, not the elbow joint. Since I'm using my left arm to record the video, I'd expect it to be done by you on your own. After that, as you are feebly feeling the pulse with your right palm, you need to raise the upper limb abruptly above the level of head. On doing so, now the pulse becomes much stronger. That is, the bounding nature of the pulse due to rapid upstroke and the collapsing nature of the pulse due to rapid downstroke become exaggerated. You will be able to appreciate the diastolic runoff of the pulse. The reason the arm is lifted above the level of the head is because of two reasons. Number one, due to gravity, more blood falls down and there is exaggerated ejection. And number two, the arteries are in more line with the aorta. As a result, there is a rapid ejection of blood as well as a rapid downfall, exaggerating the phenomenon of bounding and collapsing pulse. And this is how you elicit water hammer pulse. Next is condition of basal wall. See, I've seen lots of medical students while mentioning the characteristics of pulse say that the pulse rate is this much, the rhythm is this, the volume is this, character is this, and the vessel wall is not palpable. What I don't understand is that every time you are feeling the pulse, you are feeling the wall of the artery bulging out and striking the tip of the finger. So you feeling the pulse is actually you feeling the wall of the artery. Then how can you say that the wall of the artery was not palpable? What you really need to differentiate between is whether the artery wall is thickened or not. Because there are conditions where the artery wall is not supposed to be palpable. But if it is palpable, even in that condition, that means the artery wall is thickened. The question is, what is that condition? That condition is when there is no pulse traveling through the blood vessel. Because it is only when pulse is traveling that the vessel wall outpulses, strikes the tip of your finger, and you are able to feel the pulse by feeling the wall of the blood vessel. But let's say if pulse is not traveling, the blood vessel wall will not bulge out, it will not strike the tip of your finger, and you will not be able to feel the wall of the blood vessel. You will only be able to feel the wall of the blood vessel if here there is extra blood vessel. There is extra wall of the blood vessel, that is the blood vessel wall is thickened. Got it? Got it. Okay. So normally the blood vessel wall is not thickened. Abnormally, not thickened. Abnormally, there is thickening of the blood vessel wall. And this thickening is seen in conditions such as Monckeberg, medial, calcific sclerosis, which is mostly seen due to aging in old age. There are two ways to test for the thickness of the wall. Number one is the trisection method and number two is the Osler's sign. First, let's look at the trisection method. In trisection method, you use your three fingers, the index finger, the middle finger and the ring finger. With the index finger, you press and prevent the flow of blood from the radial artery. With the ringed finger, you press and you prevent the flow from the palmar arches or the backflow from ulnar artery. Then you milk out the blood vessel. Once you milk out the blood vessel, there is no blood inside the artery and there is no pulsation coming from the radial artery or the palmar arches. Then, with the help of middle finger, you roll over the artery. Since there is no pulse, the wall is not going to strike the tip of the finger, and normally the wall of the blood vessel is not going to be palpable. It is only when if the wall of the blood vessel is thick that you will be able to feel the wall of the blood vessel. This is the trisection method. So in trisection method, you use 3 fingers. With the help of distal finger, you block the return from palmar arches or ulnar artery. With the proximal finger, you stop the pulse from the radial artery, and then using both the fingers you milk out the artery, and then with the middle finger you roll over the artery and try to feel for the wall of the artery. Normally it is not felt, it is felt if it is thickened. Second is Osler's sign. This is Osler's sign. Hear me out. So what did I say? What is the technique? Eventually, the technique is that you want to stop the pulse from reaching the blood vessel. And when there is no pulse and you palpate the blood vessel, if the wall is not felt, that is normal. If the wall is felt, even if there is no pulse, that means the wall is thickened. So you want to stop the pulse. In trisection method, you stop the pulse with the help of your finger itself. So with the help of proximal finger, you stopped the pulse from radial artery. With the help of distal finger, you stop the return from the palmar arch or ulnar artery, and with the help of middle finger, you palpated the artery. In Osler's sign, what you do is either you use your finger to block pulse at the level of brachial artery, apply pressure at the level of brachial artery, that is proximal to the palpating point, proximal to the radial artery, you apply pressure in the brachial artery, or you use a BP cuff. Okay. The better method is use a BP cuff. You preferably use a BP cuff. You wrap the BP cuff around the upper arm. You inflate the BP cuff. Till when do you inflate the BP cuff? You inflate the BP cuff till it is above the level of systolic blood pressure. Okay, because only when it is above the level of systolic blood pressure will the flow of blood be stopped, will the flow of pressure wave be stopped, will the pulse be stopped. Okay. How do you know that? You know that by palpatory method. You must know the palpatory method of measurement of BP. So you apply the palpatory method of measurement of BP. You keep on inflating the BP cuff till pulse is not felt. So now above the level of systolic blood pressure, the pulse is not felt. At this moment, when the pulse is not felt, if the vessel wall is also not felt, that is Osler's sign negative, and that is good. That's normal. But if the vessel wall is felt even though it is pulseless, that is Osler's sign positive. That means the vessel wall is thickened. Understood? Understood. Okay, this is Osler's sign. So here's the radial artery that you need to palpate. Here's the brachial artery that you need to block to prevent the flow of pressure wave forward. The occlusion can be done either with the help of the finger, but preferably you use a BP cuff. Then you inflate the BP cuff till when? Till the pressure is more than systolic blood pressure, because beyond systolic blood pressure, the pressure wave is blocked. It is no longer going to move forward. And when the artery is pulseless, you try to feel for the wall of the artery. If the wall of the artery is not palpable, that is Osler's sign negative, and that's normal. If the wall of the artery is still palpable even in pulseless condition, that's Osler's sign positive. That means the artery is thickened. Okay, with that, we move on to delay. You have two types of delay, radioradial and radiofemoral delay. Normally, when you feel for the peripheral pulse, for example, the radial pulse, you feel for both the radial pulse at the same time, and both of them should be felt at the same time. From both the radial artery, the pulse must be felt at the same time. Another, radial artery and femoral artery as well, same thing. When you feel the radial artery and femoral artery, from both of them pulse should be felt at the same time. If one is felt before other, that means there is a delay. The delay can either be in between the two radial arteries, or in between radial artery and femoral artery. If it is in between the two radial artery, we call it radio-radial delay. If it is between radial and femoral artery, we call it radio-femoral delay. First, let's look at the causes of radio-radial delay. You don't need to mug up, you can use your logic here as well. You need to know the basic anatomy of circulation of blood, where the blood is coming from to supplying the upper limb. See, this is the ascending aorta, then the arch of aorta, then the descending aorta. From the arch of aorta, on the right side comes the brachiocephalic trunk, which splits into subclavian artery and the common carotid artery supplying the right side. On the left side, you have the common carotid artery and the subclavian artery arising separately. So, for radio-radial delay, what can happen? Number one, from below upward. Here is your aortic valve. There can be supravalvular stenosis. Supravalvular stenosis. Supravalvular stenosis, which is associated with Williams syndrome, which is characterized by a triad of congenital supravalvular stenosis, mental retardation, and hypercalcemia. Along with that, you also get to see, due to supravalvular stenosis, something known as Coanda effect. What is Coanda effect? See, here is a glass of water, and let's say you pour something out of this glass of water, right? You're pouring, let's say, glass of water containing water. You're pouring something out. When this water falls down, it trickles down and then touches the wall of the glass and then it falls down. This effect is known as Coanda effect. So the water, as it falls down, it touches along the wall of the glass and then it falls down. Similarly, in supravalvular stenosis as well, as the left ventricle contracts, what happens is that as the left ventricle contracts, the jet of blood has the preference to take the right hand side. So the jet of blood that gets squeezed out from the contraction of the left ventricle, in case of supravalvular stenosis, has a preference to follow the right subclavian artery. As a result, the right-sided upper limb pulse comes before the left-sided. Not only that, the right-sided upper limb pressure is more than the left side. So that was the first cause. See, another thing that you need to know is that all the causes of radio-radial delay and radiofemoral delay will also lead to difference in blood pressure in upper limb and difference in blood pressure in upper and lower limb. I think that's quite logical. Okay, second is aortoarteritis. Let's say this subclavian artery has aortoarteritis or Takayasu syndrome, same thing, aortoarteritis, also referred to as pulseless disease. As a result, the flow of blood from here is less and the flow of blood from here is more. Third is coarctation of aorta, but pre-subclavian, before the subclavian artery. If there is pre-subclavian coarctation of aorta, more blood will go from here and less blood will go from here. So this is pre-subclavian coarctation of aorta. And then there's last. Let me draw a separate diagram. So this is the arch of aorta with subclavian artery arising from brachiocephalic trunk. This subclavian artery travels from above the rib, right? This rib is attached to the T1 vertebra. But sometimes you might have a cervical rib, that is rib which is attached to cervical vertebra. This is your cervical rib. As a result, As a result, the subclavian artery gets squeezed in between the cervical rib and the first thoracic rib or the first rib. This is a part of thoracic inlet syndrome. See, this is what I mean. There is the C7, there is C7. So sometimes rib might arise from C7 and then get attached to the first rib and then cause stenosis or narrowing here, compressing the subclavian artery. So less blood will go from here, but more blood will go from here, causing a difference in blood flow between the two upper limbs. With that, you are done with radioradial delay. So the causes of radioradial delay are, number 1, supravalvular stenosis. Number 2, aortoarteritis or pulseless disease. Number 3, coarctation of aorta but pre-subclavian. And number 4, cervical rib. Radiofemoral delay. Again the same thing. Here's the arch of aorta, brachiocephalic trunk, subclavian artery supplying the right side, the left common carotid and the left subclavian artery. If there is coarctation of aorta after the subclavian artery, in this case, blood will go into subclavian, but then the blood flow is obstructed to the lower limb. So it will cause difference in blood pressure, difference in pulse in the upper limb and the lower limb. So first cause is coarctation of aorta. Post subclavian. Another cause could be if within the descending aorta there is some sort of blockage, then there is obstruction to the flow of blood, and this blockage could be either in the form of atherosclerosis or embolism or tumor from outside, whatever, and that will lead to radiofemoral delay. So that's your delay, radioradial delay and radiofemoral delay done. Finally, we have the peripheral pulses. Remember, the sequence at which the peripheral pulses get transmitted is the carotid pulse, followed by brachial pulse, then the femoral pulse, and then the radial pulse. Since the difference in sequence of transmission is in milliseconds, you can't really appreciate the sequence by palpating these pulses. To palpate the peripheral pulses, you are going to use 3 fingers: the index finger, the middle finger, and the ring finger. With exception of carotid artery, and at some literature, it has been written brachial artery as well, for which you use your thumb. However, in some literature, it has been mentioned that you are not supposed to use your thumb to palpate pulsations because thumb has a strong pulsation of its own. So if you use your thumb to palpate other arteries, you might feel the pulsation of your own thumb rather than feeling the pulsation of the artery that you are trying to palpate. But for now, just remember, for all the pulses, we are going to use these 3 fingers, and for carotid artery pulse and brachial artery pulse, we are going to use the thumb. Starting off with the carotid artery. So the location of carotid artery pulse is at the intersection of the anterior border of sternocleidomastoid muscle and the superior border of thyroid cartilage. So right here is the intersection between the superior margin of thyroid cartilage and the anterior margin of sternocleidomastoid muscle. So this is where you are going to keep your thumb and palpate the carotid pulse. The carotid pulse is palpated against the transverse process of cervical vertebra. Okay, so below here I have shown you how to palpate the carotid pulse. You use the thumb of the opposite hand to palpate the pulse. That is, if you are palpating the right carotid pulse, you use your left thumb, and if you are palpating the left carotid pulse, you use your right thumb. That kind of comes off naturally as well if you try to palpate the pulse. Remember, while palpating peripheral pulses, you palpate the pulse on both sides simultaneously, that is the right and left pulses simultaneously, to compare and contrast between the two pulses. But you never do that for carotid artery, because if you palpate and press upon the carotid artery of both the sides simultaneously, it might lead to cerebral perfusion. It might lead to reduced cerebral perfusion. Okay, next is brachial artery. The brachial artery is present in the cubital fossa, medial to the biceps brachii tendon. So here's the cubital fossa, here's the biceps brachii tendon, and medial to the biceps brachii tendon is the brachial artery. So you either use your thumb or the index finger and the middle finger to palpate the brachial artery present medial to the biceps brachii tendon, to palpate the brachial artery which is present medial to the biceps brachii tendon. Next is the radial artery. The radial artery is palpated on the wrist, on the anterior surface of the wrist, lateral to the flexor carpi radialis tendon. So the radial artery is present lateral to the flexor carpi radialis tendon. So you grab the arm of your patient and at rest it should be semi-flexed, and at elbow it should be semi-pronated. A semi-flexed wrist and a semi-pronated elbow. With semi-flexed wrist and semi-pronated elbow, you palpate lateral to the flexor carpi radialis tendon. Here is going to be your radial artery. And you use your three fingers, the index finger, the middle finger, and the ring finger. What's the function of each of these fingers? The index finger, it blocks the return of pulsation from the palmar arches. The ring finger, it stabilizes the artery over the bony prominence. And it is the middle finger that is actually used to palpate the pulse. Again, the index finger is used to block the reflection of pulse from the palmar arches. The ring finger is used to stabilize the artery over the bony prominence, and the middle finger is actually used to palpate the pulse. You need to palpate the pulse on both the hands simultaneously to compare and contrast between the pulses to see if there is any radioradial or radiofemoral delay. Up next, we have the femoral pulse. Femoral pulse is palpated at the mid-inguinal point just below the inguinal ligament. You can palpate the femoral pulse and the radial pulse simultaneously to see if there is any radiofemoral delay. Next is your popliteal pulse. The popliteal artery is present in the popliteal fossa, and the fossa is present behind the knee. Within the popliteal fossa, you have the upper triangle and the lower triangle. You palpate for the popliteal pulse in the lower triangle, in the lateral half of the lower triangle. Because as the popliteal artery travels from the upper triangle to lower triangle, it moves from medial to lateral. That is why you press in the lower triangle on the lateral aspect. So to palpate the popliteal artery, it is difficult as compared to other pulses. It is more difficult to appreciate. What you need to do is keep the patient in supine position, flex the knee, and then strongly press over the lower triangle in the lateral aspect. Next is the posterior tibial pulse. The posterior tibial artery is present around 2 cm behind the medial malleolus. It is present around 2 cm behind and below the medial malleolus. So you palpate it around 2 cm behind and below the medial malleolus. One trick that I am gonna tell you is that to palpate posterior tibial pulse, you ask the patient to perform plantar flexion. When there is plantar flexion, the posterior tibial artery becomes lax. Because if it is dorsiflexed like this, the artery would be stressed and it would be difficult to palpate the pulse. You can palpate both the sides simultaneously to compare and contrast between the two posterior tibial pulses. Then you have dorsalis pedis pulse. The dorsalis pedis artery is present lateral to extensor hallucis longus tendon. So the pulse is felt lateral to extensor hallucis longus tendon against the navicular bone. Lateral to extensor hallucis longus tendon against the navicular bone. Lateral to extensor hallucis longus tendon lateral against the navicular bone. So here for dorsalis pedis artery, you ask the patient to dorsiflex so that the artery becomes lax and you can better palpate the pulse. You can compare and contrast between both the sides. And with that, we are done with pulse.